All right. Good morning, good evening, everyone. We can get started. Today's conversation is with Dr. Tushar Patil, and I'll get more into it as we go along. But quickly, a couple of housekeeping items first. We will answer any questions that you may have. So please ask them in the chat window, and we'll get to them in the last 10 minutes or so of the conversation. If you're not already a member of the Longevity Circle, it's free. It's hopefully very insightful. And all you need to do is click on the link that Sneha will post in the chat or scan the QR code. As you know, we've been doing this 12-week series with Dr. Saurabh Sane. It's a 15-minute session every Wednesday at 9 p.m. India time, 8:30 a.m. Pacific time. And we get into one specific topic where he does a live sort of set of exercises around things like migraines, vertigo, neck pain, tennis elbow, and so on. We finished 9 weeks, 3 more weeks to go, and the list at the bottom tells you what the topics for the next 3 weeks are. So if you haven't already joined, Sneha will put a link to the Strength and Mobility community, and you can join that to be a part of it. If you miss the sessions, the recordings are available a couple of days after the session. All right, our speaker for next week is Dr. Supreet Bajwa. He's an orthopedic surgeon. He is on the show next week because we have had a number of our existing participants who have actually used him for their hip replacement surgery, and that's always a great stamp of approval. And so he will be our speaker next week. So tune in if that's a topic of interest to you. On to our speaker for today. It's Dr. Tushar Patil. His background is up on the screen, but I don't think that does him justice. To me, while I've heard of Dr. Tushar Patil before this from a number of people, he's a very, very well-known oncologist in Pune as well as the neighboring big cities. He is considered by many doctors I know one of the hardest working doctors. And when doctors who are already hardworking say that he's one of the hardest working doctors, he must really be very, very hardworking. Apparently, the joke is that he does 2 shifts every day for every day of the year. That is very, very impressive. But to me, the number one reason why I was excited to speak to Dr. Tushar Patil today was, when the doctors you trust go to a specific doctor for their own family, issues, then it tells you something about how special that doctor may be. And so I think for that reason, it was a no-brainer in my mind that we wanted to bring Dr. Tushar Patil onto the community podcast. And I'm glad, Tushar, that you agreed to do it. So, Tushar, without further ado, welcome to the community podcast.
Yeah, thank you. Thank you for the kind introduction. Yeah.
So, Tushar, let's start with the fact that, when you decided to become a doctor, you had a lot of options. You could have become anything. Why did you choose to become an oncologist? Was it a personal experience, an excellent sort of teacher or mentor who inspired you, or a topic that you were always drawn to from the beginning for whatever reason? What was the primary motivation?
After my MBBS, I went on to KF Mumbai for my postgraduate MD medicine. And during the second year, we have a rotation. It's a 2 to 3 months rotation in every of the super specialty wings. So during our hematology, that is blood cancer and blood disorders, super specialty posting 2 months with Dr. Faraj Jijina, who was right there. The ward, which was the hematology ward, consisted of all the blood cancer patients. And right across that window of that ward was Tata Memorial Hospital. So when we saw the suffering of these patients and many of these blood cancer patients, how they got cured. So they were brought in a very, very bad shape, bleeding from every side, fever, numerous infections. And at the end of the 3 weeks or 4 weeks treatment, they were going home happily with the disease in remission, and then further treatments to be taken over. So that excited and that offered a ray of hope. Plus, it sounded that this is the real need for the patients. So oncology is very close because we are trying to alleviate the suffering of our patients who are the most, what we say as hardest sufferers. This is something which is a shocker, not just for the patient, but their caregivers and their family. And the journey, it's not just about curing the patients, but making the entire journey worth it and soothing. That is more important. So not
Yeah.
always can be cured, but many times, many patients and their relatives come back to us that this patient ultimately could not make it, but the way you served this patient throughout his or her journey was remarkable, and that's what we say as they respect.
Yeah. No, that's such an important point, Tushar. I've seen both my parents go through it. The My mom didn't make it, but the part that always has stayed with me is not just the fact that she didn't make it, but the fact that she suffered at the end, and that you cannot unsee, you
Absolutely.
cannot unexperience it. And at least I remember another relative of mine who went through the whole journey, didn't make it, but it was a much smoother experience at the end where the pain and suffering was much less. And I think that is something that is highly underestimated and underappreciated. So I'm glad you brought up that point, Tushar. I think that's so, so valuable. And I know there are people on the call today who have gone through their journey. The fact that they're on here today means they've been able to make it. But I'm sure they can speak to their experiences as well about how much the suffering is probably sometimes the harder part, not just for the one going through it, but also the caregivers who feel helpless. They can't do anything. All they have to sort of is observe and watch, and that's hard. Yeah. Um, Tushar, you spoke about within oncology, you became a hemato-oncologist, so like blood cancers.
So starting,
Uh,
yeah.
is that so? Now, do you do more than that, or is that in itself a big enough space?
No, so I'm not just a hemato-oncologist. I studied in that ward. That gave me the inspiration to work for these cancer patients and right across for Tata Memorial Hospital. So I do general oncology, medical oncology, including breast cancer, lung cancer, colon cancer,
Hmm.
and blood cancers too.
I see. I see. And so, we hear the terms, like in the US, it's called primary care physician or general practitioners or all the different terms. Then we hear oncologist, then we hear oncosurgeon. When someone thinks that they may have an issue, people don't always know that they have cancer.
Correct.
What is the journey for a person to figure out? Because many people won't go directly to an oncologist if they're having a backache. Uh, and sometimes it shows up in different ways. What's the journey that one should, that's the most optimal to be able to figure this out soonest to get to the right person?
So I think primary care physicians, that what the general practitioners, what we call, and the medicine and the surgical guys are the primary doctors in most of the cases that see a patient, at least in the rural areas and the semi-urban areas. In urban areas, because there is an access, the moment a lady finds that there is a breast lump, she doesn't visit the general practitioner, she goes to a breast surgeon. But that
Mm.
doesn't happen in a semi-urban or a rural setting. Most times they will go to their primary care physician who would investigate primarily. Once he finds or she finds that there is something suspicious about cancer, would refer it to the oncologist or the at least the second generation of surgeons and physicians. So this is how the ladder is, and that's so most of the time when the patients come to us, it's already worked up. Like they've got a sonography or CT scan done. Most of them have a biopsy also done with them, and few of them also have a PET scan done for the staging purpose, which is there. It depends entirely on the access to that particular patient or to that person. Yeah, very important.
And sir, when does one decide to first go to an oncologist or first go to an oncosurgeon? I would imagine first oncologist, right?
So the trend is now changing. So
Hmm.
as the fields evolved, so I think 75 years back, it was only surgical oncology because there was nothing in chemotherapy that we could offer. After surgical oncology, the second treatment which was offered was radiation to burn the cancer cells.
Hmm.
So after every surgery, radiation was being offered to most of the patients. And chemotherapy actually started some 50, 60 years back only. It was close to 1960s, 65 when the first drugs came into picture. World War II, as we can remember, they used poisonous gases and some of the chemicals which cured cancer patients. Like Hodgkin's lymphoma was a blood cancer, and it was found that these chemicals, when they were used in the war, were curing some of the Hodgkin's lymphoma and blood cancer patients. So that is how the discovery of happened, and then few inventions happened. So chemotherapy started some 60 years back. It evolved over a period of time, and then the importance of medical oncology came. And now today is such an evolved field that probably medical oncologist is the fulcrum of care for an oncology patients. Many times, a patient who is diagnosed with whether it's a breast lump or it's a colon cancer would first seek an advice from medical oncologist and then go to the, or they would be directed from there towards the respective specialty.
Yeah, that makes sense. I also always wonder why would someone go to a, but this historical perspective definitely creates a lot of clarity. So, Tushar, the journey of cancer, it starts, we all at the common man level know it starts from a single cell and it expands. But can you explain for this audience what, how does cancer go from this one cell? We hear things like, oh, it spread to the lymph nodes, but I don't know how many of us really know what that really means.
Correct. I think cancer is a pathogenic cell. What it means is a ball of cells which has a potential to metastasize, that is, migrate from the cell of origin or the organ of origin. What differentiates a non-cancer and a cancer is that non-cancerous tumor will reside at the same place. Simple like lipomas, which are there, what we they're fat deposits, or fibromas, which is fibrous deposit. They will continue to grow very, very slowly, but they will never breach the barrier of that organ or the site. They will not cause any harm to the subject. Cancer is exactly opposite. The cells would multiply in a very, very erratic fashion. Technically speaking, the cell division is a very, very regulated process. So one cell gives rise to two, then two gives rise to four. When there is a sufficient amount of cell number present, the cell division stops or halts. Now, when this process of cell division becomes erratic and there is no control over the second generation of cells, these keep multiplying. Because they multiply very fast, they accumulate something called as mutations. And they are faulty cells. So they do not have a proper DNA, they do not have a proper mechanism to survive. As these cells increase in leaps and bounds, it forms a ball of cells called as tumor. 1 centimeter tumor, that is, imagine a 1 centimeter cube of cancer tumor has 1 billion cells. So today it is estimated that by the time a cancer becomes 1 centimeter in size, it's already metastasized through the way of blood by breaching all the barriers. The second pathogenesis of cancer cells is to spread to the other organs. So a breast cancer cell will go to the axilla first, that is the armpits, and from there it will travel via the blood route to different organs. It could be liver, it could be lung, it could be bones. There is a benign tumor, that is fibroadenoma. Again, I'm talking of breast only. Fibroadenoma is a benign, non-cancerous tumor of the breast. It has no tendency to go anywhere. It just resides there. Maybe a little bit of growth may happen, but it will not damage the cell. It will not damage the subject. It will not go to any other place. It will not eat up the nutrition of that person, and it will not cause any harm to the subject.
Right. Right. So when they say it has gone to the lymph nodes,
Correct.
what does that mean? Is it gone basically to the armpits and that's sort of
Correct.
where things is spread from?
So lymph nodes are the first draining site. If you get a dental infection, the tonsils enlarge, or if you get a sore throat, the tonsils enlarge. The infection gets accumulated in tonsils where our body system tries to fight it. If the body system is not able to fight it there, then you get a lot of fever and it can spread to other, what we say as lymph nodes also. Similarly for cancer, a cancer originating in the thumb, skin of the thumb, will go to the what we say is trochlear lymph nodes first and then to the armpit lymph nodes. A cancer originating in the breast will go to the armpit first and then it will go from, it's a station, what we call station. Station 1, station 2, station 3, so on and so forth. So there is a way it progresses. Very rarely there is a case where a tumor is very, very small, but it has already gone to the other organs like brain or liver. It usually follows the pattern, any cancer.
I see. So, as you were saying this, one thought struck me. I know as a kid, my tonsils were removed when I was like 5 or 6.
Correct.
Is that today something that one would not do, like not
No,
take out the
no.
tonsils?
So tonsillectomy is being done because they get infection, they get pus formation, and they cause a lot of troublesome, what we say as respiratory problems. So tonsils are a part of traditional lymph nodes in the neck. It's called adenoid ring, and there are not just tonsils. There are multiple other lymph nodes are there. In children, if they get recurrent infections, these lymph nodes swell up and they cause obstruction to the air passage. So many times they cause severe infection and they cause obstruction, causing deformities in these children. Problems. Only removing tonsils will not predispose them to a higher risk of infection.
Got it. Got it. Understood. This is helpful, just because I think many of us hear these words, but we don't understand what it actually means.
Correct. Correct.
So, you've been doing this now for a while, Tushar. And we keep hearing people talk about genetics plays a role, lifestyle plays a role. How do you think about how much genetics? I know it's hard to quantify maybe, but qualitatively, how do you think about this?
I would put cancer risk factors into two. One is modifiable, the second is non-modifiable. What are modifiable? It's your lifestyle. If you're taking a lot of red meat, if you're smoking, alcohol, other addictions which may cause or predispose to cancer, or workplace related chemicals. So asbestos is one, or tar chemicals are known to cause. People working in chemical industry, tar industry, are known to have bladder cancer and lung cancer, so on and so forth. So these are modifiable risk factors. Non-modifiable, something like age, which is non-modifiable. We know that cancer cells keep forming in the body. They continuously are formed, right from your birth till the death. They're being formed. Our body immune systems, host immune system, are the ones which, what we say, as recognize and kill these cancer cells. The moment this recognition is faulty, the killing is faulty, that is the time they will accumulate into 1, 2, 4, 8. This happens with age. This happens with diabetes. This happens with low immunity. Very typically, you can see patients earlier. Now it's very uncommon, but patients who are suffering from HIV and AIDS had cancers very early into their lifetime. So, person who is 25 years of age getting a cancer, cervical cancer, females, is almost unheard of in non-HIV or non-AIDS patients. The immunity is so low that any cell can attack the body and, what we say as, make it as their home and destroy the host cells. So this is age, immune defense systems. There are some genetic predispositions which cause cancers, and it is estimated that amongst all cancers, 8 to 10% are genetically linked. This is very important because till now, world over and even in India, they were thinking that genetics does not play a very important role. But now that we started doing those tests and realizing that no, 8 to 10%, that is 1 in 10. There is some familial risk. Possibly we cannot mitigate that risk, but for these people, we can screen them more frequently. And the second is their entire family can be screened, and if somebody is positive for that particular mutated gene, they can be cautious about it. It's called preventive screening and preventive, what we say as genetics, I would say. And evolving as a field now.
So, there's so many important things you just said in Tushar, in the last couple of minutes, that I want to double click on some of them. The genetics. So today, if there is someone who comes to you and you find out that, in their family, there has been history, what are the tests what are the genetic tests you would ask them to do?
Yeah. So the blood tests which are available today, it's called hereditary cancer panel testing. It's a 5 or 10 ml blood which is drawn. The DNA is read, and the faulty genes are identified, which predispose to a person to a particular cancer. One of the commonest of what he says genes in female breast cancers is a gene called BRCA, BRCA. This is actually a tumor suppressor gene. So when it is normal, it functions as a tumor suppressor. When it becomes mutant, that is abnormal, the tumor suppressor function is gone, and then it predisposes to breast and ovarian cancers. And there is a gene called as BRCA2. There are two variants in this. BRCA1 typically affects females, and ovarian and breast cancers are common, whereas BRCA2 affects males and females. So in males, we can get prostate cancer, we can get pancreatic cancer, we can get esophageal cancer, so on and so forth. So there is a huge list of cancer or hereditary cancer panel testing the genes associated and the risks of cancers associated with these faulty genes.
Wow, while I've been familiar with BRCA1, BRCA2 because they are terms that are used all the time, I did not realize that BRCA2 is responsible for prostate cancer, which means, historically we only heard, oh, women should do the BRCA1, BRCA2 screening test, but this suggests that even men should do it to look for sort of proclivity to prostate cancer.
So medical genetics today is a specialized field and a part of oncology. Just as we divide therapeutics into medical oncology, surgical oncology, and radiation oncology, the fourth is medical genetics, which is a part of preventive oncology that is evolving rapidly. And many times it's very difficult for us to ascertain, or we may not have time to ascertain that, or any young patient coming to us with cancer, any two cluster cases in the family coming as cancers, two siblings suffering from cancer, one first and second generation suffering from the same cancer or different cancers. We always refer to them to the medical geneticist who digs into their history, ask them to get the relevant tests done, and once the tests are available, then give them a proper advice.
Yeah. And I want to just sort of reiterate the point, Tushar, you just made. I mean, I run a company called GenePart Diagnostics, which is a medical genomics company versus one of those ancestry type genomics companies. And I think it's a very important point that you just made, Tushar, for the audience. And that is because everything sounds like it's a genetic test, but there are very different types of genetics. There is the medical genomics, which is what you're referring to. And that is the more serious stuff, right? That's the type of stuff that is actionable. You can do something about it. The other stuff is the more, I would call, fun, entertaining genetics. It'll tell you why you have blue eyes, or why you have dark hair, or whatever it is. And that has its own place, but it is not to be confused, because the more fun, entertaining ones, they look at very specific parts of the genome to look for these things. Whereas with medical genomics, you almost do whole exome, whole genome sequencing to find the more serious stuff. And so this is a message for everybody in the audience, that if you have done a 23andMe type of ancestry test, it might have some snippets of information, but that is not the same as medical genetics, which is what Tushar spoke about. Tushar, is that an accurate statement?
Yeah, absolutely. And it helps in planning of so many things. I remember one case, if I have time, we can speak, maybe 1 minute.
Yes, please.
We had a patient of breast cancer, was young. Her father had prostate cancer, and both of them tested positive for BRCA gene. Now, a familial testing was advised, and her both son and daughter tested positive. Now, what is his conclusion do we draw? Yes, they have a very high risk, and it helps us in planning their entire, what we say as, future. So we ask the girl to get married a little earlier, to complete a family, and then maybe go for preventive surgeries. So if the ovarian cancer risk is very, very high, more than 70%, then after completion of family, she can actually get the ovaries removed surgically before any cancer develops. And then it's called prophylactic surgeries or preventive surgeries. It's called risk reduction surgeries. And this is the beauty of doing genetic testing, and or he says telling this, or he says subject that yes, look, the risk is very high. Do your get married early, complete your family, and then we'll be proceeding with your preventive surgeries.
Yeah, the one person who made prophylactic surgeries very popular, or at least very well known, was Angelina Jolie. I think when she did it, suddenly it became a topic of discussion. But I think the example you gave makes it all very real. This is not a science fiction. This is not theory. This is practically happening today, where if you know this, because one of the questions that people have always asked is, but if it's genetic, I'm born with it. What can I do about it? Well, this
Like,
example you just gave is exactly what one can do about it. But this is excellent. So, Tushar, wherever you get the opportunity, please share such examples because I think they
yeah, yeah.
just make it all come to life so powerfully. Thank you for sharing that. Um, I know a lot has changed in recent years, at least in the statistics. Uh, the rate of incidence of cancers, while the absolute numbers may be going up because the population is going up and there is more screening and all of that, certain cancers are going down in terms of rate of incidence, but something like colon cancer is going up. Um, what is, from your perspective, sir, how do you think about the different cancers?
I think many of the cancers which are on rise are somewhere related to our lifestyle. If you look at colon cancer, the risk who the US had this spike, US and European countries had this spike maybe 25 years back with the onset of newer chains of fast food, a lot of red meat in their diet, alcohol, smoking, everything combined together, and a totally different, what we say as affluent kind of a lifestyle. A lot of cheese and things like that, which had, of course, they had chemicals, they had substances to cause cancer, and when you take two what we say as substances together, maybe alcohol and what is tobacco or smoking, the
Hmm.
effect is not double; it's four times. The risk is four times. I'll just give you an example again here. Uh, Lung cancer, very common in US and even increasing in India. The risk to a passive smoker, not a smoker, passive smoker, is three times higher than a non-smoker. Is no smoke exposure. The risk to a smoker, if the smoker smokes one pack per day for 20 years, is 50 times higher than a non-smoker. If the same continues for 30 years, then it is 120 times higher than a non-smoker. The risk does not decrease to a normal level or a normal population level for 20 years. Many people ask this question to me. Yeah, of course, patients who are cancer sufferers, but I started at the age of 20, quit at the age of 40 or 45, and got a cancer at the age of 60. So
Hmm.
the chemicals remain in your body for 15, 20, 25 years. They're there to stay and cause all kind of mutations. We've seen cancer field carcinogenesis also. So somebody who was taking tobacco, quid in the mouth, developed a mouth cancer first. The same chemical got into the entire mucosa. After 2 years, it caused tongue cancers. After 2 years, it caused larynx cancer. After 2 years, it caused esophageal cancer. So I've had a patient who had 4 or 5 cancers of different sites, each of them early because he knew that there was a risk and he was getting screened by doing his copy, and we got him cured for all the 3 or 4 cancers that he had. But yes, this is a what we see as realistic risk, and we should always look at it how lifestyle and addictions can affect the entire what we say as life of this patient and surrounding, so people surrounding him.
Yeah. Tushar, you made this comment about passive smoker. And passive smoker, I assume, means secondhand smoke,
Okay, second one.
right?
Somebody who
And
is
I
there in
think,
your office and smoking,
yeah,
and you are a bystander.
yeah. Yeah, I think that is one of the most underrated issues.
Correct.
Well, I'm not a smoker, but if you're surrounded by people who are, or if you stand in that environment enough, you are picking up enough risk. And
Correct.
the numbers you gave between a passive smoker and a non-smoker is also pretty large,
Yeah.
which means it's important how you pick your friends wisely.
Tobacco smoke has 400 chemicals and it has
Hmm.
40 carcinogens, 40 chemicals which can cause cancer.
Yeah.
That's the problem with tobacco. Smoking and chewing, both ways, it's
Yeah.
harmful.
And Tushar, recently I also read and I even wrote a blog post about this topic of the rate of lung cancer in non-smokers is also going up, and apparently in South Asian women, it's also going up. Is that something that you have been observing and seeing in your practice?
I think in females also the cancer risk is increasing, especially lung cancer. It's equal. It's increasing even in non-smokers. Like nobody in the family is smoking, but somewhere chemicals and pollution are also to blame for that. There
Yeah.
could be simple pesticides on the stuff that we eat. It could be chemicals from the water that you get over a period of many years. It could be environmental chemicals in pollutions that you have, so on and so forth. So there are in cancer, the cause or etiology or pathogenesis is known for only around 10-12% cancers. In
Yeah.
85 to 90%, we still don't know why this happened.
Yeah.
So many patients ask us, "Mujhe hi kyun? Why me?" We have no answer to that.
And isn't lung cancer the number one killer in the
So
country?
yes, in India, I think the number one killer is head and neck cancer still. Head and
Hmm.
neck means mouth, tongue, larynx, pharynx. So because chewing tobacco is far more prevalent than smoking in India, and that
Hmm.
risk is very high for females also. So there was a study which has been done by many institutes in India, and it's found that the uh, especially the rural females, they have a lot of tobacco chewing habits, and they get into various cancers. Various cancers. There is a distinct pattern that is followed for cancers. In males, usually it's a head and neck cancer. That is, it's called aerodigestive tract cancers, which are very,
Hmm.
very common, and followed by lung cancer, prostate cancers, colon cancer. In females, there is a divide. In urban India, the most cancer common is breast cancer. It's estimated that in city like Pune, the risk of development of cancer for a female is 1 in 22. After every 22 females, female can run the risk of development of cancer. In US, this risk is 1 in 6 or 1 is to 8. And it is estimated that we'll reach this figure by 2060 or 75. So 1
In
in
India.
6 people, yeah, in India will have that enhanced risk just because of lifestyle, maybe environment changes, some industrialization, and of course, for breast cancer, hormonal changes are also to be blamed, and they cause a lot of what we say is variations, and they are increasingly causative for development of breast cancer. Obesity is turning out to be a bigger, very big risk factor for breast cancer, very big, because it generates so much of what we say as hormonal changes and estrogen in the body that all estrogen positive tumors, including breast cancers, would be on the rise because of obesity.
And Tushar, I want to double click on this point. When you mention estrogen, most people will map it to women, but estrogen can also happen in men because of
So
obesity, right?
yeah, yeah, estrogen is there. In males, it's very less. Male breast cancer is there. Out of 100 breast cancers, one is a male breast cancer. And male breast cancer is mostly linked to genetics. BRCA2 is the gene which is mostly positive and there. And somehow, if you compare the same stage of breast cancer for females and males, the male breast cancer for the same stage do poorer than the same stage female cancer.
Oh,
The
wow.
reason is not there.
Wow. Um, of the various cancers, Tushar, which cancer today or which couple of cancers have the most positive outlook and which have the most difficult outlook? Like,
Correct.
for example, I always hear pancreatic cancer almost never seems to end well.
Correct. So there is a huge list. The most important cancers that can be treated really well with chemotherapy today and did not require any surgery are blood cancers, lymphomas, leukemias, highly treatable. In pediatric blood cancers, that is children 2 to 10 years age group, the B cell ALL, which is the commonest leukemia which is found in them, the cure rates are 97%.
Oh.
Only 3% patients would actually relapse. And now there is study to de-escalate the treatment. We were doing all intensive chemotherapies. Now, in various centers around the world, the people are coming down on the chemotherapy for such patients because they are not dying of cancer. They are dying of the secondary effects of chemotherapy.
Hmm.
Secondary effects of chemotherapy have myelodysplasia, a second cancer developing in their body, so on and so forth. So there is now this de-escalation which is running in many blood cancers. So blood cancers are highly treatable. In solid tumors, breast cancer is one of the highest treatable, primarily because many of these breast cancers today in urban India at least come early to the doctor. The moment they find a lump, there is a program going on in every hospital. Screening program, mammography is easily available. Go to go to the center, do a mammography, get it tested, come to the oncologist, get it treated, something of that sort. The second cancer, which is again what we say as highly treatable, in females is endometrial cancer or uterine cancer. Because typically the symptoms of uterine cancer are that the menses have stopped, and after a few years they start getting bleed. This is an alarming situation for the females. Immediately rush to the doctor, their gynecologist, who gets them investigated. And so most of these uterine or endometrial cancers are found in stage 1. So these two cancers, breast and endometrial, are found now in a very early stage, and they are highly curable. As
How
opposed
about
to that,
how about cervical?
yeah, cervical cancer is actually coming down in numbers now today because of aggressive, what we see as reach of pap smear, which is a screening strategy. Of course, the vaccines are also now available, and there are people who are pro for this vaccine and taking these vaccines in the appropriate age group, and somehow sexual hygiene has improved. So that way, the transmission of the virus itself has gone down.
Right.
Yeah, so that's the reason why cervical cancers are quite low and lesser in number today. But these lifestyle-related cancers are on the rise, and they will continue to rise. India will become the cancer capital of the world. It's an alarming situation. By 2050, Indian Council of Medical Research (ICMR) estimates that 1 in 10 Indian will be at the risk of development of one or the other cancer in his or entire lifetime. So
Wow.
1 in 10 Indian is a huge number. That way, every city, every town, what is this, tehsil will need to have a cancer setup to deal with such many number of patients. It's
Yeah.
going to be overwhelming, I think, by 2020, 2050.
We talk about heart disease being the number one killer, but at this rate, cancer is going to catch up.
Absolutely, yeah.
And is India equipped, Tushar, in terms of training enough oncologists and oncosurgeons to keep up with this increasing number?
I remember it. So when I started as my super specialty in 2006, it was a 3-year course. We were only three admissions. We had only three admissions in a year. So three
Hmm.
people first year, three people second year, three people third year. By the time I finished in 2009, 10 people joined in. So every year, the batch became of 10. Now I think
Nice.
it's 15 or 16 every year. So one institute itself is giving so many people to the society, and there are at least 50, 60, 100 institutes. So close to almost 400, 500 oncologists, medical oncologists are passing out every year. The only problem here is the skewed distribution of these people.
Hmm.
Like I, if I am from an area like Solapur, I would still like want to settle in Pune or Mumbai. So then, even if I am from Solapur, I do not go back to Solapur
Right.
to continue my services there. The skewed distribution is the problem. But I think in the next 5 years or 10 years, as the quality of life in these cities also comes up and gets better, probably more and more people would go there and serve the society there.
And then going back, Tushar, to the more deadly cancers, when is it,
Yeah.
which
So
cancer do you hear and you think, oh God, that is probability is going to be tough?
yeah, so all the GI cancers, many of these GI cancers, the gastric, stomach cancer, gallbladder cancer, pancreas cancer, three deadly cancers. The survival for metastatic, that is stage 4 cancers, here is in the range of 1.5 years. The most problematic thing is the poor quality of life. Stomach cancer patients cannot eat, they throw up, they have blood in this, what is it, vomitus, continuously lose blood, get low hemoglobin. A gallbladder patient and the pancreas patient can get jaundice, the liver malfunctions, they get into ascites, that is fluid in the belly, and they need to be tapped. The quality of life is very poor. One cancer which I would like to highlight here is again brain cancer or brain tumors.
Hmm.
Again, very high grade brain tumors. It's called glioblastoma, which is the highest or most aggressive variant. Again, very aggressive tumor. Regardless of what you do, surgery, chemotherapy, radiation, the survival today also has not improved beyond 2.5 years. That's the worst, what we say, one of the worst cancers in terms of his survival that we see.
And it sounds like you were saying earlier, in most of these cases, nobody knows why it happens, what
Correct.
caused it, and therefore what they should change. The only thing is, I guess we can all take away is if the better the quality of life, the lower the probability. There's no way to eliminate, but you can lower probabilities. Is that a
Yeah,
right way to think about it?
yeah, that's the way to think. And of course, detox some or the other way. is more important again. So,
Yeah. So Tushar, I wanted to double click on what you just said about detox because uh, I'm sure when you say detox, you have a specific set of things in mind. But one of the things that we are seeing happen now is there are all these detox juices and cleanses, and they're all very hype marketing, no value. So when you say detox, can you give examples of what you would consider in that bucket?
a very healthy lifestyle. What our sages used to do long many years back or many centuries back. Fruits, vegetables, antioxidants, yoga, meditation, proper activity, 1 hour of activity, 8 hours of sleep, a rhythmic body, a proper circadian rhythm which is to be maintained. So you
Right.
go to bed early, rise early, all those things which we have forgotten today. Somewhere is creating troubles for us.
Yeah.
Somewhere.
Yeah,
All that.
and I think, what is always fascinating is the secret to a healthy living is as simple as what you just said.
Absolutely, it's
But
very simple.
the problem is because most of us want a quick fix, then we go for these. Okay, if I just pay some money and get some pills and
Absolutely.
some drink some fancy juices, but that's not how we become healthy. We become healthy by just doing the basics.
Very basic things to be done.
Um, is so today there is this the number of treatments that are the options that are there, Tushar, are way more than they were like 10, 20, 30
So,
years back, and it seems to be improving every passing day. What are some of the things that you are excited about in terms of therapies?
so I think every part of cancer oncology or oncology has been a revolution now. Let's go to the diagnostics first. Diagnostics. What has happened? Earlier we were doing biopsies. Today we don't do biopsy only. We do molecular testing. So lung cancer earlier was treated only with chemotherapy, all advanced lung cancer. Today in half of them we don't require chemotherapy. A simple tablet can work. Half of them can go for immunotherapy. Again, chemotherapy is not required. So things are evolved that way. If you're going into the deeper molecular aspects of cancer and cancer pathogenesis, then many of these secrets can be unraveled, and we'll know what best treatment. It's called tailor-made therapy. So every patient is different. Of lung cancer is different, and he or she will behave differently. Treat them according to their cancer tumor type and the genetic type. It has made a tremendous difference. Cancer patients in lung cancer were living 1 year earlier, 6 months earlier, then 1.5 years. With the targeted therapies and the precise, it's called precision oncology. Today, people are living beyond 4 years and 5 years. So that has definitely changed in lung cancer. So with, this is just about diagnosis that we've changed. The tissue is not just processed for biopsy, but it's processed for a molecular testing. Similarly, if you go for very simple testing like ultrasounds, CT scan, X-rays, today nobody is doing that. We are doing PET scans. So PET scan has revolutionized our treatment. We know when to do a PET scan at baseline, after a few months when the patient is on treatment. Once the patient completes treatment, do a PET scan at maybe regular intervals to know if there is an early relapse happening, so that we can catch it early and treat it early. So this is revolutionary. And PET scan is now just not just one PET type of PET scan. PET scan is now dependent on the cancer type, and these are also evolving. There are now therapies based on PET scan, which is called radioligand therapy. The same dye which is used to detect the cancer for prostate, it's called PSMA scan. The same dye, when given in a higher concentration, will kill the cancer cells, prostate cancer cells.
No.
So it's a
Wow.
radioligand therapy, a very, very precise therapy again, which is being used. So this is about diagnosis. There are a lot of revolution that is already happening, and there's so many to come. Uh, about treatment part, surgical, we know phenomenal what is the improvement is happening. From radical surgeries that we were doing, opening up the entire abdomen, taking out so many organs, today we are doing minimally invasive surgeries. Hardly any cut scene, hardly any scar scene. Minimally invasive with a great precision. We are doing robotic surgeries. We are doing laparoscopic surgeries. Huh? In radiation, we are doing advanced radiation modalities like with linear accelerators, so that the other tissues, surrounding tissues, are not burned. The best radiation modality today is proton cancer, a proton beam therapy, which is again available in India at two centers, one in Chennai and one at Tata Memorial Hospital. And of course, there are a few more centers which will be coming up in the next 1 or 2 years. So it will be a boon for patients, especially children, where if we are giving radiation to the brain, there could be a stunting of the brain and the spinal cord. And this is typically the role of proton beam therapy, which is very, very precise and avoids all these damages to the adjacent organ. If we talk about chemotherapy, again, chemotherapy, I think it's been a tremendous ride, and the way it has progressed from a very very toxic treatment, people fearing and literally not taking treatment, to a
Right.
very 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 soothing daycare based treatment. It's like a picnic. Patients come in the morning, have their breakfast, have their lunch, go back in the evening. Next day they are working, or maybe another 1 or 2 days they rest, and the third day they are working. They can do most of their stuff and work or at home or on site with all the precautions taken. To add to this, we've had targeted therapies. To add to the benefit, we've had immunotherapies. To add to this, we now have vaccines which are being developed, therapeutic vaccine, not the diagnostic vaccine, but therapeutic vaccines which are being developed. And in the next 8 or 10 years, we'll have plethora of vaccines for treatment of cancer,
Hmm.
for each related towards a particular, what we say, is type of cancer. And our entire effort here in oncology has been cure where it's possible and make it like a controllable disease, just like diabetes or blood pressure, where it's not possible to cure. So to make it a chronic disease, it was what is the attempt, and partially we've been able to do that. We've been successful in doing that.
That's so encouraging to hear, Tushar. And of all the vaccines, I know cervical cancer has a vaccine.
Yes,
Are
there's a
there any
preventive
other
vaccine.
cancers available today, Tushar, that have a
So
vaccine?
hepatitis B is causing liver cancer, and hepatitis B vaccine is available. You can take
Hmm.
that vaccine. So cervical cancer vaccine is not just for females. It was, I'm just busting the myth here.
Yeah.
It's also for males, where it prevents the genital warts, and that can give rise to papilloma and cancers. So males also it's recommended.
Yeah.
In females, ideally it's recommended in the school or college going age, where they have not been exposed to the human papillomavirus. So before marriage, especially, and when the HPV exposure is not there, and that is the best time to give this vaccine. They are very safe. The myth is that it's caused reactions and so many problems, but I think for any vaccine there could be some infusion site reactions. There could be mild, what we say, is body ache and malaise or a fever after the vaccination. But most of these vaccines are highly recommended and they're very safe. Soon they will be introduced into our immunization program. The government is probably trying to do that. Then it will be available free to most of the children, school-going children, especially the females who run the risk of development of cervical.
Is there any vaccine that's coming up for a specific cancer on the horizon, Tushar, that you're excited about?
Different trials now. Russia has developed a vaccine, but there are strict regulations as to how it can be brought in. So uh, I think next 5 or 7 years will be the time required for
Got it.
vaccines to go through all that stringent process and get approved by FDA.
Yeah. Tushar, I'm going to ask you two more questions before we move to community questions. I have a lot of questions, but I think this conversation has been so exciting that we'll probably get through half of them. First one, does fasting help? Because there's always this conversation, fasting helps, fasting doesn't help. What is your take on it, Tushar?
My take is that starving yourself does not starve the cancer.
Hmm.
That's one word or one sentence.
Got it. So do fasting for other reasons, but not because it's somehow going to help with your
No, no,
cancer.
no, it doesn't help. In fact, many of these patients, they stop sugars, they stop carbohydrates, and they want a very, very stringent diet. Ultimately, what happens at the end of 2 months of chemotherapy, they're not able to tolerate this chemotherapy. You have to stop the chemotherapy, which is the most important treatment of their cancer. And then there's no way they regain the strength for next 1.5 months. By the time they regain the strength and we are able to give that, it's too late. The cancer has come back. So I think to fight cancer, you need all the strength, and consult your dietitian, consult your oncologist before uh, uh,
Yeah.
taking all that diet advice. WhatsApp gives you information, not knowledge.
Yeah. 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 I think this is the cleanest, clearest answer on this topic. So that's super helpful, Tushar. And the last question before we move to audience questions, how much does mindset influence cancer outcomes?
Absolutely, it's a very, very important part. So there is something called as a physical healing, and there's a psychological part also. And the strength of the mind gives strength to the body, ability to fight it, and even the resolve to get through that entire treatment. I I always give an example of exam to most of my patients. I tell
Hmm.
them that you've got an exam. Your first paper is of surgery, second paper is of chemotherapy, third paper is of radiation. You have to go through all these papers to pass the exam, and your result would not be after the completion of radiation, but 5 years. So, so that's the example I give, and possibly there are a lot of patience required. There will be ups and downs, physical, mental, social, economical. There'll be so many pressures from your relatives, from what we say as people who are around you. There'll be pressures from communities around you, and really, I think you should listen to your oncologist, listen to your dietitian, listen to your the psychologist who is taking care of you. And there are no patient caregiver groups which we have made where they discuss amongst themselves how to navigate this entire journey.
Yeah, yeah. No, I think that's very, very good advice, because the problem is when people get cancer, their immediate community, neighbors, everybody wants to be helpful. But in trying to be helpful, they sometimes give advice that is very wrong. And then when you're constantly getting overwhelmed with advice and you're so desperate to make things change, sometimes you take that wrong advice. And I've seen that happen enough number of times, and I'm sure you see that. Half your time probably is spent in trying to tell people what not to listen to as much as what to listen to.
Absolutely. Completely understand.
Right. Let me ask the questions from the community, Tushar. First, Kedar asked, how much is the personalized immunotherapy mRNA vaccines for solid tumor cancers like pancreatic cancer an effective approach and accessible as treatment options?
So definitely in India, mRNA vaccine is not recommended. I think all these vaccines are coming up a big way. And vaccine is what? It's a part of immunotherapy. You're trying to fight against cancer by what we say as modifying the immunity to fight against those cancerous cells, which is now available in many of these cancers. But unfortunately, for pancreatic cancer, we do not have immunotherapy working. Only for a few select subsets, pancreatic cancer, the immunotherapy works, which is available in India. But I'm sure these vaccines are going to come a big way in the next 5 or 7 years. There are RNA vaccines, there are telomerase vaccines, there are so many vaccines which will be seen in the 8 to 10 years spectrum.
And Tushar, in general, not for pancreatic specifically, but in general, what is your view on immunotherapy by cancer? Are there certain cases that you would absolutely recommend immunotherapy?
Yes. So there are cancers where chemotherapy has no role. If you advance, one of the biggest cancers or killer is renal cancer or kidney cancers. Till the time we were using chemotherapy, we had 1% responses, 2% responses. Slowly we understood that immunity plays a very important role. And our own immune system can sometimes kill these cancer cells. That was realized. And then came the era of interferons and interleukins, which was used 50 years back or 20 years back, but they were very, very toxic. And now in kidney cancers, we are using immunotherapy, and we are getting 80-90% of these patients surviving beyond 5 years. Similarly, liver cancer, HCC, what called hepatocellular cancer, is one cancer which does not respond to chemotherapy, and then it responds beautifully to immunotherapeutic interventions. So there are cancers which respond really well.
And so, are there cases where you would say, oh, for this specific person, immunotherapy may not be the right thing because of a genetic background?
Yeah, we're doing that. So we are doing a whole lot of molecular testing on the biopsy specimen that we get. There are tests like PDL1, there are tests like MSI. These are very complicated terms, I would say. And your oncologist or somebody who is trained in this will be able to better explain. But immunity or immunotherapy has a role in 20 to 30% of cancers overall. But the advantage of immunotherapy is that once this immune system is activated, that switch remains on for a very long time. So you give immunotherapy for 1 year and the patient is responding, you stop the treatment for 1 year, after 1 year, and the immunity, what we say is activated immunity can take care of the cancer for the next 4 or 5 years.
Oh, wow.
So we've had patients where in the interleukin era, again, renal cancer or kidney cancer, where this patient has received the interleukin some 10 years back, and for 10 years the tumor has vanished. There's no disease. This is the beauty of immunotherapy.
Yeah, that is impressive.
Chemotherapy will not have such responses. You give chemotherapy, the tumor will shrink. The moment you stop the chemotherapy, then after some time, maybe 3 months, 4 months, 6 months, the tumor will start coming back.
Very, very interesting. Manish's question is, are standard annual health checkups adequate for meaningful early cancer detection, or should screening increasingly move toward a more personalized, risk stratified approach based on individual factors such as family history, genetics, etc.?
So now we are doing that. For females, usually it's recommended that starting at the age of 21, you do a pap smear, in India at least, and starting at the age of 40, you do a mammography yearly. But for females, where there's a strong family history, two females in the same family are suffering, then you take the youngest case in the family. Suppose the youngest case is 35. She she started having that cancer at the age of 45, 35. Then the subject who needs to be screened should be screened 5 years earlier. That is 30 years of age, something of that. But these are evolving fields, but a screening strategy has to have a meaningful difference or make a meaningful difference in the survival. So not every move or every strategy will be helpful. Like for lung cancer, you can't do CT scans for every person to see if there's a cancer developing. But today, for heavy smokers above 55 years of age, we are doing something called as a low dose CT scan, which is not very harmful. And this can be done at a yearly interval to screen a small nodule which is coming up. And if this nodule is increasing in size, whatever is happening, if required biopsy, so on and so on. For females, two screenings, breast cancer, pap smear is recommended. For males, the only thing which is recommended is a testing called as PSA, prostate specific antigen, starting at the age of 45 and to be done yearly. At the age of 50, you do a colonoscopy. And if it's normal, then do a colonoscopy after 10 years. But no other screening strategies. I would, what we say is, warn all people against doing random testing, like tumor marker testing. They do CEA testing, CA 19.9 testing, CA 120, which is a part of the tumor marker package. Now, this creates panic among so many people. A CA 125, which is just 5 points above your normal level, can be because of so many inflammations and infections in the mouth. And people come to us every day. I see one or two patients of this kind. They are feared and totally panic-stricken. Yeah, absolutely panic. Sir, my CA 125 has gone up. Do I have ovarian cancer now? Everything else has turned out to be negative. So please don't do any tumor marker testing. Do what is recommended as per the guidelines.
Yeah. And one thing I wanted to add to what you said, Tushar, is until about 3-4 years back in the US, 50 was the age group for colonoscopy. Now, given the high colon cancer rates, they have dropped it to 45.
Absolutely. Yes. So I'll just give you an example here again. That Japan, after the bombing which happened, and they suffered so much of human loss and genetic makeup changes that happened. Plus, this soil there has a lot of nitrosamines, the sand and soil there. They eat a lot of smoked food, which causes development of stomach cancers, the GI cancer, which is very high. But this has been a boon for them. Now, in Japan, they do a upper GI scopy, that is an endoscopy, maybe every 6 months because the risk is very high. And so they are able to find out stage 1 and even earlier than that cancer. It's called stage 1A, precancerous lesions. And they are the masters in something called as endoscopic mucosal dissections, EMR, where if there's a cancer found out in the esophagus, you don't have to remove the esophagus. You just can scoop out the cancer from that layer and the treatment is done. So probably indirectly it served as a boon for them, and they are masters that. They are supposed to be the best people around the world for GI, stomach cancer, stomach related and colon related cancer, because the incidence is very, very high.
No. Saurav asked, would you advise to test family if somebody from the family is tested positive for BRCA? Any certain type of cancer that has more chances to transmit genetically, breast, ovarian, for example? Yeah.
So we discussed that. I think BRCA1, breast and ovarian are very common, and usually in females. If somebody is BRCA, so imagine a female who is BRCA positive, BRCA1 positive, her siblings need to be screened and her lower generation needs to be screened. And whoever is positive, then again the same siblings and the second generation needs to be screened. Something of that sort.
Yeah. Sachin asked, what should caregivers focus on during and after treatment?
Caregivers, I think the most important part is to help them psychologically. Physically, of course, that's their duty that they are doing. Psychologically, there's so many ups and downs, emotional turmoils during the cancer treatment. Patients try to give up. They won't listen to things. They develop aversion to food, nausea, loss of taste, hair loss, figure changes. So many things happen in the body and mind, and the entire what it says journey can be soothed by these patient caregivers who can give them the right advice, support them thoroughly, and of course, I personally make it a point that if there's somebody who I feel that is a little bit jittery and obviously is not coming to terms, I make them talk to another patient survivor who's
Hmm.
gone through a similar journey, and what has he or she done, what we say, overcome this entire situation. So that is the best way of dealing with this, and that brings in a lot of confidence in these patients. They are able to navigate. They are able to take this journey in a positive manner. That helps quite a lot in completing the treatment on time. That's more important. If the cancer chemotherapy has to be done in 4 months, and if it takes 8 months, it's of no use. The
Yeah.
cancer is sure shot to come back.
Yeah. Yeah. No, I can't sort of reiterate that point enough. Tushar. In fact, one of the things I found is to be a source of positivity, because
Correct.
every day that's all. And one observation I had with my mother was the hardest time for patients is in the night, because then you're alone with your thoughts,
Absolutely.
and that's when negativity comes in. And so because I have to visit from the US, in many cases I was jet lagged. Staying awake with my mother in the night, I found, was the most valuable, because during the daytime there are enough people around you, right? There is enough reason not to get into your own head.
Absolutely. So negative thoughts come usually at that time only, in the night time. And yes, support is of paramount importance.
Yeah. Uh, we'll just do a couple of last few questions. After cancer treatment, what usually helps reduce the chances of recurrence further in life?
Okay, I think if your cancer treatment is over, the cancer recurrence depends on mostly the stage of the cancer and the diet, whether you've been taking the entire treatment properly or not. First is that, and second is that whatever has to be done for a healthy lifestyle has to be maintained. So if the if cancer is, again, breast cancer example, estrogen positive tumor, and the treatment is completed, now the patient is on hormonal tablets. If the patient keeps on putting weight, the estrogen is bound to increase, and that's going to increase the risk of relapse of this patient. Second, the hormonal tablets themselves cause osteopenia and osteoporosis, which because of obesity again will increase. So they will be at a loss because their function would be going down. Their bones will become less healthier. There is an increased risk of fracture, increased risk of decrease in the quality of life because of fracture and pain and so many things, which also are important. Also, survivor care, what we say, survivorship today has become very important part of our plan. It's not just navigating through their chemo, surgery, and radiation, but beyond that also, the next 5-10 years, which these patients take to recover and then they become healthy individuals, is most important. How they recover and recuperate, and giving
Yeah.
them the right guidance.
Yeah. But one point that you have made a couple of times, Tushar, and I think it's super important for everyone to take away is, while age is always going to be one big risk factor for cancer, obesity, which is an increasing problem, is
Absolutely.
as big an issue, right? The way it is evolving.
Good. Very true.
How useful are full body scans? And I think you already sort of answered this question.
Absolutely.
You're going to find unnecessary information, but it's being marketed so heavily that people
Yes.
think, what's the downside? I might as well do it. But there is a downside, because it will give you information, it will cause you panic, and you'll spend the next 3 months trying to identify this phantom ghost disease.
Right. Right. I'll just give you an example again here. I would like to quote an example.
Yeah.
During the COVID times, when people were suffering from COVID and they were having respiratory problems, there's so many patients where they got the scan done because of of course, they wanted to check for the level of the COVID and the infection spread in and that increased the detection of lung cancers by many folds during the COVID period. Because many of these patients, or to be patients who were asymptomatic, they had no symptoms of lung cancer, just came for a COVID testing. They became positive for COVID. They got ill. Got hospitalized. They got a CAT scan done, and this CAT scan picked up a lung lesion, which was probably a cancer. It was boon for them because many of these cancers are early cancers. So that was an era where this, and then it fortified the notion also that for high risk patients, possibly a low dose CT scan should be done. So now it's a what is a recommendation today. Yeah, we're doing that.
And let me ask the last question, Tushar, from Kedar. For autoimmune disorder women patients who have to be on immunosuppressants, what preventive or proactive investigations would you recommend, and at what frequency?
Again, we are not very sure whether these immunosuppressants can heavily increase the risk of developing cancer or not. But we've seen a couple of patients, like there are a few patients who were on immunosuppressants for rheumatoid arthritis and colon, some other autoimmune bowel disorders, and they developed cancers. Patients who are especially on methotrexate, drug like methotrexate, but there are no different recommendations for screening them or anything. Recommendations of screening are there for inflammatory bowel disease. Patients who are suffering from Crohn's disease and ulcerative colitis, they are at a very, very high risk of development of colon cancer, and they need to be screened more frequently for colon cancer. The stool testing does not suffice here because stool will have blood in most of the cases. Ulcerative colitis patients start bleeding and they have stool in the blood. So colonoscopy here will be more important for them to screen for the development of cancer.
Yeah. No, there are questions that are keeping on coming, Tushar, will never end. But it's a sign of how much people have enjoyed and taken value out of it. So I'd love for the audience to show you their love with how much they enjoyed it. And
we can always take up their questions. You can pass on my mail ID, and maybe if it's on the mail, we can find time to answer those as questions or myths rather.
Yeah, exactly. No,
I think
but
we
this is
about myths. So one question about one last sentence about myth. There are a lot of myths about cancer. Cancer in all stages is incurable. Again, a myth. First myth. Second, cancer is contagious. Is absolute myth. Don't sleep with the cancer patients. Don't eat in the same plate. So many things are there. Keep the patient isolated. You don't be doing the patient as is already isolated from the society. He's already gone into a mode where he or she tries to isolate herself or himself, and you're trying to more isolate physically and socially. This patient is the worst thing that can happen to a cancer patient. All these are myths. Chemotherapy is dangerous. It's too toxic. But so people are just putting their sentences in a very, very unregulated manner, and which needs to be properly taken care of. Listen to a scientific advice is my take on that.
So I think this is a great way to end, because I think if we can just surround cancer patients with love, everything else, there are experts, but love has to come from the environment. And I'm so glad, Tushar, that there are experts like you who not only do a great job, but you've taken the time to share all of these learnings with us. I know we are all going to walk away that much more equipped to help the loved ones in our life that are going through it. So thank you so much.
Yeah, thank you. If there are any doubts, queries, I think Nikhil is there, and everybody can coordinate with him. We'll be happy to answer their questions, queries, or any advice. Yeah. Thank you. Have a great good night.
Yeah, good night. And thank you, everybody. Bye.
Thank you.
Thank you.